Hello everyone, my name is Linda Krantz. I'm the Associate Director of Preventative Health. I cover all of the skincare and infection control for Masonic pathways. I want to let you guys know that skincare is a high priority at Masonic Pathways, and I want to share some things that we want to make sure that you know. CNAs, you are often the first line of defense, and it's so important because you spend the majority of your day with the residents more than any other discipline. We want to make sure that the nursing staff are listening and working closely with the CNAs. Listen and assess. Anything that the CNAs see during their AM and PM care or during the day needs to be communicated with that nurse. The areas of pink on this body are areas of pressure. And when you're providing your AM and PM care, we want you to especially pay attention to these areas on the resident, these areas where pressure areas could occur, especially behind the ear. If a resident has oxygen therapy, the tubing goes around their ears, they should have the foam covers on that tubing. And when you provide care during the day, we want you to make sure you look under that tubing, make sure that there's no redness, pink areas, and notify the nurse. Also, look for swelling of the feet, edema. Notify the nurse of any skin conditions you see. Anybody that is resting in bed should never have their heels on the bed directly. We want to make sure that you put down pillows to elevate their heels off the mattress. We have heel risers. It's really important because as they move in bed, it causes friction and that could create pressure areas. Stage 1 pressure area is intact skin, non-blanchable redness at a localized area, usually over a bony prominence. Darkly pigmented skin may not have visible blanching. The areas may be painful, firm, soft, boggy, warmer or cooler as compared to adjacent tissue. It's really important that you identify any areas, pink or red, that do not go away. Notify the nurse immediately. These are some pictures of a stage 1 pressure ulcers, and if you look at the heel, that is a stage 1, and that's what we want to prevent by elevating their heels off the mattress. If you see someone that's self-propelling their wheelchair without shoes on, that can cause friction on the heel too. It can cause blisters. We want to make sure that they have proper footwear on if they're propelling their wheelchairs. We want to be proactive and not just reactive. Anybody that has incontinence, we have to make sure they have a skin barrier, whether it's calmoseptine or blue goo, we have to have a barrier. Stage 2 is a partial thickness loss of dermis, presenting as a shallow open area with a pink wound bed without slough. So it'll be red and there won't be any yellow or black. It'll all be red, so we know it's 100% granulation. May also present as an intact or ruptured serum-filled blister, and it appears shiny or dry, shallow ulcer. A stage 2 are pressure ulcers. They're not skin tears, tape burns, perineal dermatitis, maceration, or excoriation. These are examples of the stage 2 pressure ulcers, and you see that there's granulation tissue there. It's bright red. We want to see that. If there's any areas that are slough yellow, discolored, then that will change the treatment. We want to make sure that it's red tissue. That'll help getting it healed more quickly. Pressure ulcer versus incontinence associated dermatitis. That's why it's so important that anybody, as I said before, that has incontinence has a barrier cream on them. And if you see any excoriation, notify the nurse immediately. If a resident is admitted to the facility, we have skin sheets made out of their whole body, so any impaired areas are identified on that sheet, and then we start treatment immediately. If an area develops after admission, the nurse is notified. She has to make out an incident report. She notifies her supervisor, and we do a conference call. That is with the manager of the unit or myself and the DON. We want to make sure that we get to the bottom of how this occurred. We take it very seriously, so anytime you see any new area, it has to be notify the supervisor immediately. Prevention of pressure ulcers. We want to keep the area clean and dry. Avoid hot water. Use mild cleansing agent. Pat dry. Don't rub. That can cause friction. Keep linens wrinkle-free. We do not use any draw sheets on the nursing side at all. When you do that, that can cause friction. We have maxi slides that we use to reduce that friction. And it's easier on the resident and on the caregiver. Moisturize the skin with AM and PM cares. Lotion on their legs, their heels, their whole body. That is beneficial to keeping their skin hydrated. Reposition per plan of care, profile, and as needed. Proper positioning and transfer technique. Weekly skin checks with nurse to identify new areas of concern. And I want to really pay attention to that. A resident is scheduled for a shower a minimum of 1 time a week. When that shower takes place, the CNA needs to notify the nurse that you will be providing that resident with a shower. That nurse will come in and she will be doing a skin check along with you on the resident's body to ensure that they have no impaired skin at all. If she does find something, as I said before, she'll do an incident report and notify the supervisor and the manager. Float heels. We have gel boots, and we have easy boots. We have elbow protectors and wheelchair seat cushions. Anyone that is sitting in a wheelchair should never be sitting in that wheelchair without a cushion under them. We have enough cushions in the facility that should not be a problem. If you can't find a cushion, notify materials management and they can bring one up. Prevention of incontinence-associated dermatitis. Check resident for incontinence a minimum of every 2 hours in PRN. Follow the care plan for this. During the night, the midnight shift, many times we will use the overnight briefs. That allows for them not to be check and change as frequently. It gives them a better night's sleep than being awakened every 2 hours. So follow the plan of care. Cleanse with no rinse pH balance personal cleanser. Pat skin dry, do not rub. And again, moisturize. We want to make sure there's a barrier ointment in place. If perirectal area is denuded, use zinc-based extra protective cream. If you do use the zinc oxide, make sure that you're putting a very light coat on and you're not washing that off every time and rubbing it, because sometimes that causes worse irritation from that rubbing. Tidbits to remember. CNAs always communicate to the nurses any skin changes, including any edema to extremities, as this increases the risk of ulcer development. When I do rounds, if I see a resident that has swelling, edema of their lower extremities, I always notify the nurse. That resident maybe needs to have their medication, their water pill, diuretic increased, and we need to maybe have them the last to get up for their meal and the first to lay down, elevate their legs, maybe elevating footrest too we use to decrease that swelling in their feet and legs. And nurses always remember new skin concerns to the unit manager, initiate acute change of condition documentation. If you do find a resident with any skin impairment, as I said, we'll do an incident report and we'll do a conference call if it's after hours. But we want you to document every shift. We want to make sure that we're pushing fluids. If it's indicated they can have extra fluids, we want to monitor their intake and output. If they have skin impairments, they may have had weight loss or some other condition going on acute. So we want that documentation to try to get to the bottom why their skin suddenly has declined. And unit managers shall assess and notify the DON and preventative health care for further assessment and intervention. The following day, we always notify the dietitian. They come in immediately and they assess to make sure that they have enough calories, they're getting enough intake to prevent further breakdown and to heal what's present. Infection control. As I always say, these guys really do exist. They exist on tabletops, anything that we touch. And we want to make sure that you understand that by following our policies here that you can reduce the infections that occur in our unit to the residents, to yourself, and that you might hopefully not take home to your families. What is the number one way to prevent infection? And everyone knows hand washing is the answer to that, but we don't always wash our hands as much as we should. When you come on the unit, that's the first thing you should do before getting your assignment. You should wash your hands. And before you leave, at the end of your shift, you should wash your hands. Hepatitis A can cause jaundice and diarrhea. Staphylococcus can cause zits or boils. Pseudomonas can infect wounds, staphylococci. I'm delighted it says to give you a sore throat. We see these infections on our unit and we see them in ourselves. Shigella can cause diarrhea, and Staphylococcus pneumoniae, among other things, they love to give you pneumonia. And I follow the infections that are occurring on the unit, and I have a mapping system that shows every room in the facility. So on any given unit, every month will get a report of the infections that we're seeing on the unit. And sometimes I've been able to track down that it's a group that maybe one CNA had. There may be 3 urinary tract infections in her group. And when we see that, we put things into place. I may come around and watch pericare to make sure that we're following our policy, that we're washing our hands, that we're wearing gloves, that we're wiping from the front to the back, that we're changing our washcloths per protocol. And I actually did this a couple years ago, and I found that staff didn't have enough washcloths on their shifts in order to provide the care that they needed without spreading infections. And so it was a simple fix. We notified ES, and they gave us, or the laundry, they gave us extra linens, washcloths, and towels. And our infection rate did go down. Currently, our infection rate for UTIs is high, so I'm going to have to do some more rounding to try to figure out why that's occurring. And hand hygiene is really important. We want to make sure that we wash our hands before we perform any care to the resident. Before you touch a resident, before clean aseptic procedure, after body fluid exposure, after touching a resident, after touching a resident's surroundings. So you might touch a tabletop. Anything that the resident touched on that table could be infectious, and you don't really want to think along those lines all the time, but you really need to. So if you move something, or hand them their water mug, before you leave the room, you should wash your hands, because you don't want to pass that on to the next resident. Standard precautions includes all residents. And personal protective equipment, we have masks, gloves, gowns, and the purpose is to protect the resident and ourselves from spreading infections. Transmission-based isolation precautions, we have airborne, droplet, contact, C. difficile, and if you're not sure what to do in a case of if someone has one of these precautions, just the policy is easy accessible, and also in the cart that materials management brings to the unit, there's laminated precautions listed. So once you find out what precautions the resident has, it's laminated. It tells you exactly what you need to do and what type of infections that entails. Airborne, it covers measles, varicella, chickenpox, and disseminated zoster shingles. We do see shingles from time to time on our units, and as long as the shingles are covered, they're not draining, then we will allow the resident to come out. And airborne precaution also includes TB isolation rooms. We have negative pressure rooms 116 and 117. I've been here 11 years and we've never had to utilize those. And we did just update our TB policy. If a resident has TB newly diagnosed, we will make sure that they are in a room by themselves. If possible, we want to make sure that they have a mask on, but we will be sending those residents out to the hospital. we will not keep a resident that is newly diagnosed with TB. We want to make sure that any resident that has precautions, that there's a stop sign placed outside their door. And everything in that cart that materials management brings up will have what you need: gowns and gloves and mask. Droplet precautions: when a resident has influenza, mumps, we want to make sure that the door is closed if they're coughing and sneezing and there's a chance that it could come out into the hallway. We want to err on the side of caution, and we do try to keep them in a private room. We want to make sure that if that's not possible, that we keep them at least 3 feet away from the other resident. The curtain's usually pulled, and we usually go over that with the resident that they're rooming with also. Contact precautions: we see more contact precautions, and that's because of cellulitis that's maybe not contained. We occasionally have had lice here in the facility, and we have good success rate on not spreading that from resident to resident. But we want to make sure that we follow our guidelines. Multi-drug resistant infections, MRS and VRE, we will have that. Many times we see that on residents coming into the facility. And we have things in place before they come in. We'll have the sign up, we'll have the cart outside the door, and we will explain that to the resident when they come in, what our precautions are, what it entails. I never go over how to don and doff the protective equipment. When the time comes when you need to wear this, if you have any questions at all, just let nursing know and we'll be happy to go over that with you. But most CNAs and nurses have the use of using this equipment and taking it on and off. Just want to stress that if someone is in isolation, you want to make sure that you remove your equipment, your protective equipment, prior to coming out of the room. Tidbits to remember: always remember to wash your hands with soap and water after caring for a resident with C. difficile. Equipment should be washed between residents. If possible, we try to keep a blood pressure manual cuff in their room and stethoscope and blood sugar monitoring. Stop signs, again, should be outside the room. And if they're in isolation cards can be obtained from Donna Brown and Materials Management. And we want to make sure, stress too, the tops of the cart need to remain empty. We don't want to put any magazines I see sometimes and other items. That should all remain clear. Please notify Infection Control Manager with any infections needing precautions, and so we can track that. The managers on the unit, anyone that is started on an antibiotic is put on this audit, and we monitor to make sure that we have the proper McGear's criteria to support the use of that antibiotic. If not, we notify the physician and we will have that antibiotic stopped. Thanks for your attention, and if you have any questions or concerns, my extension is 3016. My office is on the second floor just outside of the dining room, and our door is always open, so let me know if there's anything I can do to assist you. Thank you.